Good afternoon. Welcome to another edition of the Aspire webinar series. Our topic today is pre-treatment to improve gamete quality prior to ART. Oftentimes, we hear about strategies that are being implemented in patients who are scheduled for IVF. These strategies can be in the form of vitamins, supplements, or actual therapeutic drugs, or simple lifestyle modifications. The target patients include men with abnormal sperm, women with PCOS or endometriosis, or even normal men and women who are for IVF treatment. So our goal this afternoon is to talk about the practical recommendations for such, probably review a bit of the evidence so that we can give good recommendations. My name is Professor Virgilio Novero from the University of the Philippines in Manila, and I'll be your moderator this afternoon. With me are three Asian Pacific experts who will help us navigate through the maze of treatments. First is Dr. Madhuri Patil, who is the clinical director of Dr. Patil's Fertility and Endoscopy Clinic in Bangalore in India. She's the associate editor of Fertility and Sterility and the official publication of ASRM, and chairperson of the Aspire Special Interest Group for Reproductive Endocrinology. Second is Professor Louise Hull, who leads the endometriosis group and the fertility and conception theme at the Robinson Research Institute. She's also the deputy head of the department, University of Adelaide, and she's part of the medical advisory board for Aspire and was chair of the local organizing committee for the Aspire annual meeting in Adelaide in 2023. And last but not the least is Dr. Haroon Latif, who is an accomplished clinical embryologist and clinical sexologist. He's chief executive of the Lahore Institute of Fertility Endocrinology, or LIFE, the managing director of the Hamid Latif Hospital in Lahore, and is the president-elect of the Aspire. Welcome, ladies and gentlemen. May I remind our participants in the audience that you can send questions as we go through our discussion issues through the Q&A box. So let's get on with this roundtable discussion. We have limited time to talk about a lot of topics. My first question would be, do you pre-treat patients routinely prior to IVF, meaning even patients who are normal young men with normal sperm or young women with normal ovulation and normal anatomy? Do you pre-treat these patients? Can I start with you, Professor Patil?
Yeah. So basically, if they are normal in the female, I would just start on preconceptional folic acid, but I would not really give anything else. And in the male, after we evaluate the sperm parameters, and if we find they are normal, they don't have any sexual problem, I would really not start anything before I go for IVF if it is required, or for any other infertility treatment.
Thank you, Madhuri. How about you, Louise?
I would be very similar. I think the main other thing, particularly for younger people, is just making sure that you've had a bit of a look at their diet and lifestyle and whether they smoke or drink a lot or have a lot of coffee and those kind of things. But we'd certainly look at a pregnancy multivitamin. And generally, we're now suggesting that men have a general male multivitamin. But I wouldn't really use too much more than that, provided there was no other issue.
Yes, and also from Haroon, would you do any pre-treatment? You know, many patients would as if bait you that they want to take something. So would you accede to their request? What would you say?
So thank you, Joy. Exactly. A lot of patients do want something before they get on the journey of infertility treatment. I think one thing that I really focus on is lifestyle modification, because especially in men, smoking, and of course in women as well, And then if the BMI is on the higher side or any other comorbid conditions, then of course the lifestyle modification is an important factor. And I do tend to give some basic antioxidants or vitamins to both men and prenatals to women before they embark on this journey.
Yes, I think that's one of the most common things that we hear nowadays about treatment for patients, whether they are going through IVF or not, lifestyle modification, especially for these taking coffee or their weight or etc. So my question though is, it's quite easy to tell them that you have to lose weight to be of the correct weight. But what about those who are taking a lot of coffee or those who are smoking? Will telling them to stop smoking or to stop drinking alcohol, or will it improve their chances in a short span of time for the IVF treatment? Anybody?
At least they should be doing that for at least a minimum of 3 months to really see the effect, especially in the male and even in the female, because I think the chronic smokers or those who have coffee, it has been seen that the chance of fertility is almost about 50 to 60% more than a normal person. And therefore, I think telling them is easy, but many a times people may not follow because it's very difficult to follow that. And then we would probably have to postpone the IVF. So if the patient is young and the ovarian reserve is good enough, we can still wait for another 3 to 4 months. But if the ovarian reserve is poor and we need to go for the IVF much earlier, then probably we have to weigh the benefits as well as the disadvantages of advising them lifestyle modification, wherein we tell them to stop smoking or reduce the coffee intake. So I think we have to weigh the clinical situation and then advise the patient.
You mentioned about coffee.
Alcohol.
There's a scarcity of evidence regarding the amount of coffee that would make you say that you're drinking too much coffee. Some would say 2 cups, some would say even much more than that is allowable. Any ideas or anything that you practice with your patients, Louise?
We're quite lucky. We can actually measure homocysteine levels, which are kind of a marker of cellular stress. And often it's actually quite hard, particularly guys who have a normal sperm count will actually feel they don't have to do anything else. And they still will have issues if you're doing IVF, particularly, you know, you'd find even if their lifestyle wasn't very good, even though the count is normal, quite often they'll have issues either with a little bit with fertilization or day 3 to 5 embryo development. But I would normally actually run a fasting homocysteine, because often that's really quite high. And when they can actually see a blood test that is quite abnormal, they will, both women and men will actually be very good at modifying their lifestyle if they can see they maybe have a bit of a genetic predisposition or their lifestyle is impacting cellular stress for their cells. And they don't want to pay a lot of money for it not to work. A lot of people would, even if, and sometimes I have to put it in a framework of 3 months, you know, they can do what they like after they've had the baby, but if they could just give me a window where they don't drink and they don't smoke and they really watch their coffee to bring that down for that time, sometimes that will work rather than kind of never, or sometimes if they see a normal count alone, they just won't do anything. So, and vitamin D, I would normally run a vitamin D as well, because sometimes it's quite low and I can easily give that as a supplement too. So that can be quite helpful.
There's some evidence where they have given, I think, something like 250 milligrams per day. More than that will affect the fertility. But if it's less than 250 milligrams, it really does not.
I think any lifestyle modification, for instance, if you tell a patient to come back with a certain BMI of, for instance, under 30, and that's a tall target for that patient, and then the patient will be kind of disgruntled that may not be able to achieve that. And for smokers, if you ask them to quit completely, it may be very difficult for them to suddenly do that. And same with alcohol and extra caffeine intake. But if you just tell them, oh, look, whatever you do, any control would have a positive impact on your treatment outcome. And that really helps. Then, of course, even if they cut the smoking by half, they're not quitting it, cut the caffeine intake, and similarly lose weight by a few kg, even if they're not hitting that BMI target. That I feel helps when they undergo the treatment in itself, and it seems like a more achievable target for these patients as well.
I think it's quite clear to most practitioners that lifestyle modification and control of those bad lifestyle habits is important to advise patients who are about to undergo IVF, regardless of how long or how short it is. My question, though, is where everyone's talking about antioxidants, which antioxidants do you prescribe? Now, this time I start with Harun.
Yeah. So I think there's so many antioxidants, and antioxidants have been in the limelight for a few years now, and I think have become an integral part of subfertility or infertility treatment over the years. Obviously, there is mixed data available as far as impact of antioxidants on general outcome or improving gamete qualities is concerned, or the outcomes is concerned. Personally speaking, what I've seen over the years in the practice is that some patients really do respond well to antioxidants, whereas others are who really don't respond at all. For me, when I'm prescribing something, for example, to improve the sperm quality, I have two sets of options. Since I practice in a developing country where patients are paying out of pocket, so cost is one of the factors. And depending on that, I select that we can start off with simpler antioxidants or vitamins like vitamin E, C, and zinc. And then, of course, coenzyme Q10 we've seen that has really good impact in improving sperm DNA fragmentation rate and things like that. And of course, then we have selenium and L-carnitine, acetyl-carnitine, and so on and so forth. So there are quite a few. But generally, I tend to give these antioxidants for a period of 3 months' time, repeat the semen sample or the required test that's done. And if there is some improvement, they can continue it. Otherwise, we'll have to move on to some other treatment options.
We'll be going back to a little bit of those antioxidants, but we just have a burning question from the chat box from Graham Thompson, directed to Professor Hall, and he's asking, is the evidence about coffee intake strong?
I think there is some evidence if men take more than 3 cups of coffee, it can impact sperm counts. I think it's not I think if it's under that much, there's not a lot of strong evidence, and that's why it's very hard to be able to you know, give a clear indicator if people aren't drinking that much coffee, and it would be one of the lower things. I think you can rank the lifestyle things that will affect you, and smoking probably is the worst.
Agree.
I think marijuana is probably second.
Okay.
I actually think diet and lifestyle would be very poor diet, lots of carby sugars in their diet. And then I think probably coffee after that. And actually, as long as it's mild intake of alcohol, it would be at the bottom. If it's very heavy alcohol, if it's binging alcohol, where you're drinking lots in one go or 3 or 4 drinks a night, then that's a significant factor. But if you're having the odd drink every now and then, it's probably not too bad either. So I think you've got to look at the rank. If someone's smoking and can stop smoking but can't stop a cup of coffee a day, I'll take the coffee. You know, I'm not that to me is, you know, you do the best you can. And if they can, I'm like you, Haroon, if they can cut down and I can meet them halfway with some vitamins and antioxidants, that's going to be better than staying at that level and just giving up. You know, so if they can halve it rather than, you know, they won't be able to stop it, it's better than giving up completely. And I think if you can use antioxidants to kind of meet people halfway a bit, then you're kind of working on it together, and I'm sure it helps. So
Yeah.
Actually, there was a report from the ASRM practice committee which gave what's the relative risk of infertility when you take alcohol, when you take marijuana, or you take more. I think alcohol, they said more than 2 pegs. Coffee was 250 milligrams, as I said. All these increase the relative risk of infertility by 40 to 50%. That was a report from the ASRM practice committee.
Yeah.
I think published in 2016 or 17 sometime.
So if you guys have patients who have poor lifestyle modification factors, drinking or coffee or smoking, what would be your choice antioxidant? I guess you will not be prescribing all those that were mentioned by Harun, because none of them really come to all together in one pack. You'll have to prescribe all of them, or you can just choose some of them, unless you choose. There are now certain products that have put together a few of them together. So what do you do when you prescribe these antioxidants? Harun?
I think my choice would be a combination of coenzyme Q10 and with that L-carnitine. Coenzyme Q10 being 100 milligram daily, and L-carnitine or acetyl-carnitine between 1 to 2 grams daily. And I'll supplement that, especially for men, with zinc. So this is a combination that I've seen that has a reasonably good impact as far as the sperm quality is concerned.
Louise?
For men, I tend to use CoQ10 as well, and fish oil and lycopene, which is a tomato-based antioxidant for men. And for women, there's been quite a CoQ10 I like because it's also good for endo, and I see a lot of patients with endo. But the NMMs and the NATs, N-acetyl, I can't remember the last name there, but NMM and NAC are quite good antioxidants for eggs, and there's been quite a bit of research looking at that in animal models to show a benefit. But again, it's not very strong in human studies, and a lot of the studies have looked at kind of any antioxidant too. So, but I do like CoQ10.
Yes. I think CoQ10 is one of the most evidence in the literature. How about you, Madhuri? What do you prescribe?
So I basically would give CoQ10 as that would be my first choice. But in some patients who really had repeated failures, I would also go in for probiotics, because now there's a lot said about gut dysbiosis and as well as infertility. So I would probably go. There is some evidence now coming up even for melatonin, because they say that it probably helps in decreasing the mitochondrial oxidative stress. So I would use, sometimes I use vitamin E, but now I feel that it just increases the cost, and I really would not use that many combinations. And probably I think there's some evidence which is coming up for resveratrol, because it is said that it increases basically the follicular pool, as well as it increases the ATP in the oocytes, and thus improves the gamete quality.
Okay, resveratrol, these are for patients with a poor lifestyle factors. Also, resveratrol. Okay.
Virgilio, just with fish oil, you have to be a wee bit careful if for female patients about to have an IVF pickup, because it will cause bleeding. So you tend to not want to do that in the cycle, because you'll get bleeding at the pickup.
Okay. All right. Okay. So let's move away from lifestyle modification in normal patients. Let's move just a notch a bit. What about patients who will be doing IVF because of unexplained infertility? You don't have any evidence of what they are. Will you be doing any pre-treatment for these patients? Madhuri?
Lifestyle, as we already said, but probably I would just give CoQ10. I would not give much, because if we have not really been able to identify the cause, because many a times they have subtle abnormalities, like there would be subtle abnormalities either in the sperm, or they could have mild to minimal endometriosis, which cannot be diagnosed by the routine ultrasound, or even by doing just a HSG or a sonosalpingography to look at the tubes, or there could be subtle abnormalities in the tube, that is the cilia of the tube, or there could be subtle abnormalities either in the oocyte also, which cannot be identified. So that those abnormalities would be known only after we've done an IVF, and then probably later on we could probably treat this group of patients.
I agree. This unexplained infertility subset is very, very tricky. It's difficult to instill any pre-treatment, not knowing what you have that you're going against. Anything on that, on unexplained infertility, Harun?
Yeah, so I think from male factor subfertility point of view, there is a lot of evidence now that a lot of these male patients who couples have been marked with unexplained infertility, they might have a high sperm DNA fragmentation rate in their samples. So visibly the semen parameters or the reports are perfectly fine, but once you run the fragmentation index test and you find that there's high fragmentation rate. So definitely, if there is long-term unexplained infertility, I would like to run sperm DNA fragmentation index test on these patients. And if the fragmentation rate is high, then probably treat that before moving on with the actual infertility treatment itself.
Okay, before we move on, we have some burning questions in the chat box. So there's a question: what do you say about women who consider giving up work in the hope of improving their fertility and conception chances?
I would not advise, because I think that would increase the stress much more. Because when you're working, at least at the point when you're working, you are so much engrossed in whatever you're doing. So the stress of infertility really would not come, because stress really makes a lot of difference when it comes to the success rate of any infertility treatment, because we know that the stress increases the adrenal hormones, and then this in turn could result in increase in the testosterone. And testosterone also plays a very important role when we talk about if you have high levels, it could affect the oocyte quality, or it could also affect the endometrial receptivity. It can change the cytokines and the interleukins. And therefore, I think I would not advise giving up work.
Any extra thoughts on that from Harun and Luis? You think that's...
Yeah, so I think a lot of patients in our clinical settings, they, especially after embryo transfer, they would want to take some rest till the pregnancy test, and a lot of women are very keen to do that. So again, I agree with Madhuri that it's all stress management, right? If they want to rest and they feel that it will help in conception, and it might be more stressful for them to go back to work, especially during that time while they're waiting for their pregnancy test and everything. So if they're keen to rest, then of course they can rest. But technically, of course, going to work will not harm their chances of conception.
There's a separate question here. What are the panel's view on the Mediterranean diet in improving fertility outcome? We've been saddled with all sorts of diets. You know, what do you call this? IF. What is IF? Intermittent fasting, or all sorts of diet coming. And lately, they're now talking about Mediterranean diet. Would you like to comment on how these different diets would affect or improve fertility?
I was reading this in the context of MTHFR. The mutations for MTHFR, which apparently are higher in the Mediterranean area. And they think that MTHFR may be a protection against malaria, but then if you have the MTHFR, you have increased oxidative stress in your cells, but the Mediterranean diet reduces it. So if you have this high MTHFR and you use the Mediterranean diet, it's kind of a protective diet for that they feel has been, it was a theory that had been developed in conjunction with an MTHFR mutation population where that was higher. So it was quite an interesting, I'm not sure how well established that is, but it is thought that the Mediterranean diet has a lower inflammatory a response. So it tends to be high in vegetables and fish and protein, and not so much carbs and sugars. So I think any diet like that is probably helpful, but I think that's how that diet, it was kind of interesting to see how that diet might have evolved. And many of our patients do have MTHFR as well. So it's a bit of a way of combating that, I think.
Yeah. Another question here. What about vitamin D supplements? What do you think? Is there a role of vitamin D supplements in fertility treatment? I think vitamin D right now is one of the favorites of fertility doctors. And I think we have to give our 2 cents worth on this. Madhuri?
Yeah, so I feel, I mean, basically it was looked more at in women with PCOS because there was some link with hypoandrogenism and vitamin D, because they say the vitamin D deficiency used to can increase the hypoandrogenism. So otherwise, in other patients, wherever the vitamin D levels are low, I think it should be given, because it does have some effect on the C reactive protein levels, and it has some amount of anti-inflammatory effect. In PCOS, I think we could try, because there are a lot of trials going on, but we have really not reached at an evidence which really says that vitamin D supplementation is required in all patients of PCOS. So at least I give vitamin D only in those patients who have low levels, which are less than 30 international units. Otherwise, I would not just give as a blanket treatment to all my patients.
Yeah, Louise?
I certainly do supplement it, and I think it's been associated with high oxidative stress and high homocysteine levels as well. And certainly when we supplement, I measure it and supplement it, but we see the homocysteines come down in response to that treatment. So I think it does have a benefit. And I think there's pretty good evidence for supplementing vitamin D for pregnancy as well. So I think you're more likely to have a healthy pregnancy. So we measure it and supplement it.
But I think we need to know the amount of vitamin D supplementation that we should give and when to stop it, so that we know there is a toxicity for vitamin D. So
Yeah.
I think those are two different things that we need to emphasize to our patients. Even though it's the favorite right now, and not too much has been shown to be clearly of benefit, it still seems to be logical. But again, let's wait for stronger evidence. Harun?
Yeah, I concur with both Luis and Madhuri that, of course, if there is deficiency, it has to be supplemented, and it has known to impact, give oxidative stress and everything. So, of course, one has to test it, and if there is deficiency, supplementation is required.
Okay. Before we go to the next level of questions, let's just answer this last question from Graham Thompson again. In unexplained infertility, do you believe that diagnostic laparoscopy has a place? Invasive, yes, but certainly beats ultrasound to diagnose endometriosis. What do you think, guys?
Yes, I think it does have a place, because there are certain subtle abnormalities which we cannot probably diagnose on an ultrasound, both a 3D and a 2D. So in these cases, if the patient really doesn't want to go for IVF, I mean, as a first line of treatment, or after they're failed, they would really like to know what the cause is, and then probably we could go for a laparoscopy. Because in India, I think, and even in Pakistan, I mean, our IVFs are not covered under insurance, and therefore, if we could find the cause and we could treat it, it probably would be beneficial.
Okay. We'll be going up to the next, yeah.
We've been doing some research, and we've got an AI system looking at MRIs and ultrasounds to diagnose endo. And it's really interesting once you get very good diagnostics. It's about 40 to 60% of people with unexplained infertility have got endo. So a lot of the time, you can actually find the cause, and particularly if there's a mild male factor, the sperm have to also work in an environment that's inflammatory. And so if you can find that cause, it becomes even more important to be able to work as a couple to get everything else right when endo is present. And often you don't find that out till people have had lots of IVF cycles. And I think that's where getting some better diagnostics out can really, because surgery is so hard to access. But sometimes you have to do it, even with the good imaging diagnostics. But I think that will really change. That's certainly changed our practice hugely in terms of we don't see that much unexplained infertility now.
Yeah, there's a question here on PCOS, and you're starting to talk about endometriosis. We'll answer those questions a bit later. For now, let's go to a different topic, and this is how do you pre-treat patients with advanced maternal age? I am sure you will not run out of patients with advanced maternal age, and they'll be asking, what can we take in preparation for my IVF cycle? Arun.
I think, to be honest, there's not much that we can do in specialty patients with high advanced maternal age. However, a lot of data has come out over the years supporting use of DHEA supplementation for these patients. And we've also used it in our clinical practice, and we've seen some reasonable results in certain number of patients. So yes, so one thing that can be done is supplementing with DHEA in these advanced maternal age patients.
Yeah, I think for advanced maternal age, we need to talk about 3 subtopics. DHEA, again, CoQ10, and the other one will be growth hormone. Arun is ready.
Evidence only for the growth hormone and CoQ10, whereas DHEA, testosterone really do not have much of evidence. And even the T transport trial, which was just recently published, says that it really does not improve the live birth rate. And even the DHEAs really does not have much of evidence to be used. So there's some evidence from CoQ as well as only for growth hormone.
Yeah, I think that one came out recently regarding DHEA not improving pregnancy rates and live birth rate, and we really need to review the evidence. But many still keep on giving it because hypothetically it's supposed to increase the number of receptors for more follicles. That's what the theory is about. So I wonder if does anybody have anything more about any positive thing that you can say about DHEA? There's a lot of negative things about DHEA, and usually those that they talk about is 25 milligrams 3 times a day. Luis, anything good to say about DHEA?
I always think sort of DHEA breaks down into testosterone, so I tend to use testosterone gels and things like that, but I think the evidence is quite weak, and I think the initial studies were very positive, but we really haven't seen it in bigger, larger studies much. So I agree, it's very controversial. I do use it sometimes. It probably, particularly if I'm using a long down reg, it takes the edge off it a wee bit sometimes, but I'm not sure that we get bigger numbers or certainly better outcomes. It's hard to be sure of that, and I'm not sure that we can even test for it even. I think the only thing is I think they tried to do a trial and they couldn't randomize people into it either. So people either wanted it or they didn't. So I'm not sure it has a negative effect. I don't think it's something that we have to say people can't use, but I'm not sure I can hand on my heart say it's got a positive effect. So it might just improve the androgens in the fecal cells that then get converted to estrogen, which probably does have a positive impact on, there might be one egg that flips into the group or slightly better quality. So it's just really whether those increased androgens can then be converted by aromatase to estrogen and improve. So the theory is there. I'm just not sure the clinical trials have shown it to make a huge difference. So
Yeah, Madhuri, just to tell you, there's a very recent meta-analysis by Lin in 2023 at Frontiers, claiming that it improves this is growth hormone, improves outcome with shorter cycles and better outcome. I don't think I went through the evidence if these were RCTs or what, but again, this thing about growth hormone comes and goes.
Yeah, the growth, that's what I said. There's some evidence on growth hormone as well as CoQ. And there was another study which had come from China, which had published the network analysis. I think it was sometime in 19 or 20, which also said that probably DHEA does improve the pregnancy rates. That's what that trial had said. But if you look at the latest data as well as the T-transport trial, which was published now, it says that it is really not effective.
Okay.
We did a trial on growth hormone in Australia, and we were supposed to recruit 150 and we got to about 120. So it was a wee bit underpowered, but we really didn't see an effect from it. And it's incredibly expensive here. So it's $300 a day here. And
Exactly.
yeah, it's like, wow, I can give someone another IVF cycle with much better evidence and many more chances, particularly, if we're getting lower numbers of eggs. So it just becomes a little bit of cost benefit analysis here.
There was one paper by Chiri where he said that he gives only for 4 days or something, that's all, or 3 days. And he says that has improved, but I'm not very sure really whether it helps if we just give for 3 or 4 days.
I think a big barrier for us is cost, as far as adjuvant treatments, and already the IVF cycle costs so much. So that's why that's a big barrier for I guess in all of Indian subcontinent to do these kinds of adjuvant treatments.
Yes. Okay. We again move forward. I know we seem like we're touching on a very important topics slightly, but we need to move forward and talk about others. So next topic will be about men with abnormal sperm. Haroon, what can you say? Should we suggest pretreatment for men with mild or moderate or severe or even non-obstructive azoospermia? What do you think?
Yeah, so definitely, Novero, I feel that pre-treatment always helps when it comes to the clinical outcome if the patient is planning to go through an ART cycle. And so it depends on the level of abnormality in the semen parameters. For example, if there's mild to moderate, then we just talked about use of antioxidants, and they do have a role, especially CoQ10 has a role in improving sperm quality, particularly reducing DNA fragmentation rates and improving spermatogenesis in these patients. And of course, lifestyle modification we've already discussed. When it comes to non-obstructive azoospermia, then of course it depends on what is causing that non-obstructive azoospermia. For example, if a patient is with Sertoli cell-only syndrome, then of course there are no germ cells there, and any sort of pre-treatment may not help in those kind of patients. However, in other patients of non-obstructive azoospermia with, for example, hypospermatogenesis or maturation arrest, of course, then there is evidence in which hormonal treatments like oral treatments, clomiphene citrate or letrozole, and injectables, of course, HCG and FSH treatments do help in increasing spermatogenesis, and then there's a higher chance of sperm retrieval when we go for either simple TISA or micro TZ, depending on the parameters of the patient. So pre-treatment for subnormal semen parameters is required, especially when we talk about conditions like non-obstructive azoospermia in patients.
Yeah, incidentally, just a little bit of an advertisement. Aspire will be hosting a masterclass on male infertility in January in Taiwan. So those on the lookout for male infertility education. Please be on the lookout for that. Okay, any additional comments about pre-treatment for abnormal sperm from Madhuri and Luis?
Particularly when it comes to azoospermia, as non-obstructive azoospermia, especially, I would look at the hormonal levels. So if a patient has very high FSH and LH, I mean, I don't think any of the hormonal treatment is really going to be useful. So basically, they should have lower levels of FSH wherein we could treat with hormones. And letrozole basically would be helpful when the estrogen levels are higher and the testosterone levels are higher. That is, there's an altered testosterone estrogen ratio. Uh, Otherwise, basically, it really does not help, because many a times we see these patients have high estrogen levels. And when we give letrozole, probably it does help in this group of patients. Otherwise, I think what Harun said, we would do the same.
So the lesson for male is that you need to understand what's wrong. You have to understand the hormonal profile, and then you decide if they need clomiphene citrate or letrozole or even the FSH injections.
Yeah, and Joy, also we have to monitor these hormones. This is also very important. Once we've started the treatment, whether oral or injectable, we have to monitor the T levels, the FSH levels, testosterone and E2 ratio, and all of these things, depending, of course, on the patient profile and everything. Only then we would have an idea about the effectiveness of these pre-treatments.
Okay, we have to move on. We have two more. Okay, go ahead, Louise.
It's just been very interesting because I've actually been supposedly teaching some andrology fellows, and the andrology endocrinologists have really taught me a huge amount about metabolic syndrome in men, which I've always sort of worked with women. And it's just been really interesting because I've had a reasonable number of guys who've had undiagnosed diabetes or have diabetes in the family where they really have very high insulins, very poor metabolism, and also they have sleep apnea. So they're hypoxic a lot of the night, which actually, if you treat those things, they have very low libido as well. And it's been really interesting using a completely different, specialties methods of improving metabolic syndrome in men. Suddenly the sperm counts, and it's spermia rather than a significantly low sperm count. But when all the parameters are a little bit low, you can actually get that up into the normal range. And I'm sure all the cells in their body are suddenly getting oxygen and things like that if they're sleeping through the night with, actually treated sleep apnea and metabolically treated conditions. So I think we don't look at that much. I was surprised how aggressively the endocrinologist will treat that in men, and we tend to ignore it completely. So it's been a real learning step for me, but it's completely logical, really. And it was just something that's been really helpful for some of the guys who we couldn't work out what was going on. So
yeah, food for thought, especially now that we see a lot of aging men marrying a bit younger women. So something to think about too. We only have some time left, and we still have two important topics to cover. And this is women with PCOS and women with endometriosis. First, endometriosis. Do you pre-treat patients with endometriosis prior to IVF? Madhuri.
So initially, I used to give the ultra-long protocol of GnRH agonist, wherein it was said that probably it helps in improving the oocyte quality as well as the pregnancy rates. But of late, after the new guidelines have come from the ASHRAE, I have stopped doing it, and I've started using the antagonist protocol. Unless in an antagonist protocol, I have a lot of asynchronous cohort of follicles that are growing, then in this group of patients, I would definitely use the GnRH agonist, especially in poor responders as well as in patients with endometriosis. I would also like to give them antioxidants because we know that the oxidative stress is much higher in patients of endometriosis. If the follicles are accessible, I really would not go to do a laparoscopic endometrial cyst excision, basically, because this is going to decrease the ovarian reserve. And there are so many women who require repeated surgeries because usually endometriosis is a recurrent condition. So I would really not pre-treat it, and I would only give antioxidants, and I would start the treatment. I also like to give low dose aspirin in this group of patients sometimes because I feel they would probably improve the oocyte quality.
Okay. Any differing opinion from you, Luis, regarding giving or not giving GnRH agonists for endometriosis?
I probably agree. I definitely use CoQ10. I think that's got some pretty good evidence behind it. I do certainly try and use a long down reg, and my understanding is that Ture Zheng has shown that 3 months and 1 month. I don't always use, I think 3 months will actually downregulate all the FSH receptors, and it makes it hard to get a good cohort. So I don't necessarily do it for as long, but I tend to just do a long down reg, but occasionally I will do slightly longer, but I don't think, I tend not to be doing 3 months as much as I used to do that probably as well. I think the other thing, I do think surgery has a role at some point if you just cannot get high quality embryos. And I have had some people have quite significant improvements when we've tried to freeze things and then think about surgery, and it's been the surgery that made the difference. So I think if you're persistently not getting good quality embryos over a couple of cycles, sometimes you do have to just bite the bullet and get the best surgeon you can find who's going to go nowhere near those ovaries as much as they can. But I have seen some real improvements with that too. So I think it is still in the toolbox. So
I think in patients, some patients who have repeated failures in endometriosis especially, I do occasionally use low molecular weight heparin in this group. Very rarely. It would be about 10% of my.
when do you give it, Madhuri? Because you'd be worried about bleeding at the pickup.
No, so I would stop it before the pickup, 48 hours before the pickup, and then again I started 48 hours after the pickup.
Right, and you feel that improves it?
Yeah, in a few of my patients, who have, I mean, I have many patients who come to me who have had 2 or 3 surgeries, and then they had repeated endometriomas, and I have huge endometriomas, and I have already done once IVF with me, though they have already undergone outside, and I feel that the egg quality isn't all that good. I had a few pregnancies after I've used low molecular weight heparin. I said a very small percentage of them.
Do you think it reduces the inflammatory factors from the endo?
Yeah, probably. I mean, I don't know. I use the CoQ as well as I have used the low molecular weight heparin in a small.
It should have an anti-inflammatory effect, I think.
But heparin does have some amount of anti-inflammatory.
That's something we need to review. We'll check the evidence regarding
So
giving
the evidence isn't very strong on that. If you look at the evidence, it isn't there much on using heparin. Otherwise, also there isn't much evidence on using heparin in IVF, especially if we don't have any autoimmune disease.
Okay. Anything more on endometriosis, Arun?
Yeah, so I agree with Luis that CoQ10 has strong evidence that it really helps, and it not only helps in the number but also the quality of oocytes that we retrieve. However, one thing to add, otherwise I agree with both my colleagues, that we also offer oocyte pooling or embryo pooling to these patients, because more often than not, there's low ovarian reserve, the endometriosis might come back again. So that's why we offer to do multiple egg retrieval cycles so that we have a certain pool that can be used in future.
Okay, final topic, women with PCOS. And just to shorten the discussion, let's focus on metformin and myo-inositol. So what do you think? Is it worth giving myo-inositol and or metformin, or choose one or the other for patients with polycystic ovary syndrome? Let's start with you, Luis.
Well, we've been doing some research on it, and we've actually been measuring insulin levels at 1 and 2 hours in women and men, and treating with metformin, which is easy for us to prescribe and treat, and it's cheap in Australia. And we've found some we've been finding that we started off looking at miscarriage. We thought it would improve miscarriage because 66% of people in a recurrent miscarriage cohort have high insulins, and a lot of them have PCOS as well. And when we treated, people weren't having miscarriages and issues going into their pregnancy, but there's an absolute dose response in terms of predicting gestational diabetes. So I can actually tell my obstetricians who's got a high risk of diabetes and who to look after in that pregnancy before they get it. So that's been a really useful thing for us. But we've been giving metformin, and we've been finding our embryo quality's got better as well. Particularly when a lot of partners, they both have it. So I think you get attracted to people. It tends to give you sugar cravings and carb cravings. So you tend to like people who are going to take you out for dessert and things like that. I think metabolically, it's been interesting working with the andrologists as well. But we've been finding actually, and I think at the moment we're using metformin. We know it's safe in early pregnancy. We cannot use Ozempic, semaglutide, any of those things. But it will be interesting to see what happens over the next 10 years, because I suspect people are sort of feeling it's very inherited rather than related to BMI. We haven't found a very good relationship with BMI. It's definitely very related to a family history of diabetes. So we tend to treat quite aggressively. We mainly use metformin, but people who won't tolerate it, I do move to inositol. And I was actually in India recently, and they have a combined now, so where it seems to look at different aspects of the pathway. But it certainly made a big difference. It makes it much easier to stim the ovary. So if you have those really tricky PCOS people who get either 50 or 2, if we use metformin, we get a much more effective dose response, and it does reduce the risk of hyperstim. So we can stim harder without feeling that we're going to have a major medical problem when we use it too. So there's quite a few benefits to it, but also people often who can't lose weight very easily, because if your insulins are high, you can't get the sugars out of the cells, suddenly lose a couple of kilos and they start feeling better. And there's pretty good evidence that all the cells in your body will get the sugars out of them, and the enzymes will get the sugar. You hyperglycosylate the enzymes. So if you can get the sugars off the enzymes, they don't need as much energy molecules to move, and your ATP production doesn't have to be so high, so you get less free radicals and oxidative stress. So it's a way of reducing inflammation as well. And we've been finding it really interesting because it seems to make quite a difference. We're trying to publish on it. So the data with gestational diabetes is about to be published as well. But yeah, it's been an interesting thing to see.
So from your point of view, metformin does work as pre-treatment?
Yeah, and I would use it for 6 to 8 weeks. I wouldn't now do an IVF cycle with someone who I test particularly people with family history, and a third you won't pick it up on a fasting test. It'll be the 2-hour. But the HOMA does pick up quite a lot just on a fasting test. Or sometimes they have acanthosis. Sometimes you can actually make a clinical diagnosis as well. But anyone with a very strong family history of diabetes, we're finding we get really good outcomes. And they just do much less IVF. They often, I used to give it when people had test and do it when people had miscarriages, or I was fighting to get one great embryo out of a cohort of 20, and I didn't want them to have a miscarriage, and then my embryos got better. Then I used it at the beginning, and people had natural conceptions. Even people who'd had 4 or 5 IVF cycles were having natural conceptions when we treated. So it was quite a change.
So Louise will test for diabetes first.
And we run the insulins. So young people won't have diabetes. But we look at the insulin levels and treat on that.
The metformin will help in preventing OHSS. And you said there seems to be some groups who mix myo-inositol with metformin. What about you, Madhuri? what are your thoughts about insulin,
I
about
don't
myo-inositol and metformin?
I don't use myo-inositol at all. I do use metformin, and the test what I normally do in a PCOS who comes to me is an oral glucose tolerance test, as well as we do the lipid profile. If the oral glucose tolerance test is abnormal, we do start metformin, and if the patient is obese, also I do start metformin. And basically, when we are doing here, there now has been a lot of evidence which says that probably metformin increases the chances of pregnancy when gonadotrophins have been given. So if when I'm giving oral oval agents, and if the patient is not obese or does not have an impaired glucose tolerance, I really would not start metformin. But I would start if she is obese and has an abnormal glucose tolerance. And if I'm doing a gonadotrophin cycle, either for an IUI or for an IVF, I would add metformin. Basically, it prevents OHSs only in a GnRH agonist cycle, but not in an antagonist cycle. So, normally nowadays, what we use is an antagonist cycle. So, it really does not make a difference whether, when we add metformin to reduce the rate of OHSs in these patients. And normally we don't do the insulin levels as probably Louis was done, because we don't have labs which really have good sensitivity, and therefore we rely more on the OGTT. And the new guidelines says, though we said that probably decreases the incidence of GDM and all, but the new guidelines say that uh, giving metformin pre-treatment as well as during the pregnancy only reduces the risk of preterm labor, but it does not reduce the risk of a miscarriage rate or GDM or hypertensive disorders in pregnancy. But there are papers which have still been published, because I was just going through when I was just writing evidence-based guidelines on the role of pregnancy, and they do say there are papers which are published in 22, 23, which do say that they do reduce the incidence of miscarriage as well as GDM and hypertensive disorders in pregnancy.
Yeah, okay. So you also do what Luis would be doing, test for diabetes, give your metformin because it decreases OHSS. But for the patients who test negative for diabetes and has PCOS, will you give
So,
myo-inositol or OHSS or metformin or
no,
myo-inositol?
I normally don't give.
Yeah. How about you, Arun?
So I think we use both metformin and myo-inositol, and metformin especially for weight reduction. As we know that weight reduction really helps with the patient when we're going for a stimulation cycle, the response of the patient. So definitely in those patients for weight management, metformin is used, and we've seen that myo-inositol also improves ovulation, reduces insulin resistance, and at times it also helps to balance the LH and FSH ratio. So yes, in our practice we are using both. Although then again, with myo-inositol, cost is a factor which we have to keep in mind.
And what?
A lot of people will ovulate too once they've used metformin and lost weight and
Yeah.
got a healthy lifestyle, but they really get such bad sugar cravings without it that they can't do the lifestyle stuff that goes with it. But then they'll get to ovulation, and then they can have a natural conception, as
There are a
well.
couple. There are
I
a
had
couple
done
of.
a small randomized control trial wherein we gave placebo, and we in combination with vitamin D and myo-inositol with vitamin D. We had done we didn't use anything for ovulation induction. We did the treatment the male hormone levels as well as after the treatment. So we gave it for a total period of 3 months. We did not have any pregnancies in that period, and it must be only about 5 or 10% of the patients afterwards when we realized where we had given, because it was a double-blinded RCT. So only about 5 to 10% ovulated after giving myo-inositols, whereas the 90% did not ovulate. And there wasn't also much difference in the androgen levels. It was a very small study which involved only about 50 patients. So because we were just, here we don't have any grants, so we were just doing it. So we had to counsel the patients that it may or may not help them, because that's a constraint, and therefore we just had 50-50 patients.
And
Hello?
Joy, one thing just that myoinositol, generally we've seen patients who can't tolerate metformin, and there are some patients who just can't take metformin and the quality of life is affected. They tolerate myoinositol pretty well. So in even those set of patients, it can be used.
A couple of questions in the chat box. What dose of myoinositol or metformin do you give for those with PCOS? What dose?
500, 1500.
1,500 per day.
Yeah.
There are others who give it at 850 twice a day.
Yes.
Not the metformin I use, I give like 500. I tend to use slow release daily until they can tolerate it. So it stops them absorbing sugar in the gut, and the sugar will pull water in, and they'll get diarrhea if you do it too fast. But then I go up to 1 in the morning, 1 at night, just for high insulins, as long as they don't have diabetes.
Sorry, guys, we've already reached 1 hour. We're already over by a few minutes, but we need to end here. I think we only have time for you to wrap up. Any parting words for pre-treatment of patients prior to IVF? Again, we start with you, Madhuri.
Yeah, so when we look at all the pathologies what we have discussed, so I would discuss the PCOS first. So a patient of PCOS who is going for IVF, basically, I would like to give them CoQ or CoQ also, because they do have abnormalities in the oocyte. And basically what we're going to use is a antagonist protocol. So I would like to give either a progesterone or estrogen for only about 8 to 10 days, so that the FSH levels are low and we have a synchronous development of follicles. Because in my experience, what I've seen, that if I don't pre-treatment treat them, then we have a lot of asynchronous follicles, and there are a lot of follicles which are dominant, and some of them are intermediate size follicles. And in endometriosis, initially, I used to treat with the agonist, but nowadays I just use the antagonist protocol, unless I have found that I've got a lot of asynchronous follicles and the ovarian reserve is good, then only I would use the long agonist protocol. Unexplained infertility, basically, except for CoQ, I would not use anything. In poor responders or in patients who are aged, I mean, I don't use much of androgens. I don't use DHEA or testosterone in my practice, nor do I use growth hormone. So basically, it's more of CoQ what I use, and I use a minimum dose. I don't use anything more than 300, and very few patients I would use 450 IU of gonadotropins, and I use an LH activity definitely when I'm treating this group of patients who are more than 40 years or who have poor ovarian reserve.
Thank you, Madhuri. Luis?
I agree. I think the most important thing is right at the beginning. When you meet your patient, if you can get the best diagnosis you can, and then think of the best way to kind of reduce inflammation and improve their health, and look for some of those medical factors that might be really impacting that. Often if you can explain it to them, they will make those differences, particularly the lifestyle differences. And then I think the pre-treatments you need to target to the condition you're trying to treat. But things like CoQ10, there's a lot of antioxidants around that I think are probably fairly equivalent. The CoQ10, I think, has the best evidence. We generally think in most of those inflammatory conditions you'd use it, but it's sort of really worth understanding the biology there and kind of treating really appropriately for it. If you're likely to have high insulins, go for metformin and inositol. If you're thinking you're thinking trying to suppress inflammatory cycling of the endometrium, and that's where antioxidants, but also either long done regs potentially help you, or surgery. Male factor, I think Haroon has more information than me on, so I'll leave it to you. But yeah, even in young people who have a fertility problem, often there's something there. It's not very common for young people to not conceive reasonably easily. So trying to find out what that is, and sometimes it's really complex, will help you with pre-treatments as well. So
I think in some of them, stress probably a psychological counseling also would be very important. And in PCOS women, basically a group counseling is very important because we've seen that when they talk to each other and then they realize their problems, they are more compliant with their treatment protocols.
Thank you again. Harun?
So, in the interest of time, I'll just talk about male infertility. And I think, according to the recent WHO, not so recent anymore, publication also, we know that sperm DNA fragmentation index and ROS testing have become a routine part of male infertility or subfertility workup. I think we all should include these in our workups because high DNA fragmentation rates and free radical damage to the spermatozoa has great clinical implications. So until and unless we test those semen samples with these particular tests, we will never find out, and a lot of these patients are labeled as unexplained infertility. So that testing is extremely important. And going forward, of course, we've talked in length about lifestyle modification. I feel it's really, really important in men, especially factors like obesity, alcohol, smoking, and to a certain extent, caffeine also. They need to be modified, and even a certain percentage is modified in their lifestyle, it has a positive impact in the outcome. And then moving forward, of course, we have these antioxidants, which have shown promising results, especially coenzyme Q10. There's a lot of data on it, and some other antioxidants that we've named previously. So pre-treatment with these antioxidants, and in some cases with oral hormonal therapy also helps before going for an ART cycle.
I think in this context, we should also talk about the electromagnetic waves. So use of mobile phones, Wi-Fi, use of a lot of laptops, use of microwave ovens also affect the male fertility. So I think it's
Madhuri,
important.
we can't live without that anymore now. So it's a reality.
So, okay. With that, I thank our experts. Thank you for sharing your expertise. I hope our audience took some learnings with them home. And this was, I believe, was a very productive discussion of 1 hour.